Welcome back to the Radong Smart Review CNS Cancer Series.
Great to be back.
Today, we're really going to dig into a critical topic: spinal metastases, stability and cord compression management.
Yeah, this is absolutely essential stuff.
It's not just about facts, is it? It's about building that clinical skill set, that critical thinking you need when things get urgent.
Exactly. These are decisions that, really impact patients, sometimes immediately. It's practical radiation oncology at its core.
And for those who were with us last time, we laid the groundwork, right? The whole comprehensive workup for suspected spinal mets.
That's right. This session flows directly from that.
Yeah.
Builds right on top.
So what's the mission today?
Okay, mission is clear. We want to get really comfortable assessing spinal stability, nail down how to grade cord compression accurately using the tools we have, and crucially, understand the evidence behind managing malignant epidural spinal cord compression. MESCC.
MESCC. Got it.
We'll hit the big one, the Patchell trial, and talk about the conventional radiation options that are still very much in play.
Perfect. And to keep it grounded, let's circle back to our patient from last time.
Good idea.
So picture this again. 65-year-old man, known prostate cancer, shows up in the ED.
Okay.
He's got this progressive bilateral leg weakness, really struggling to walk now, and new urinary retention.
Not a good sign.
Not good at all. Urgent MRI gets done, shows a destructive lytic lesion at T8, and it's causing severe epidural spinal cord compression.
Okay, classic scenario.
And you're on call. The neurosurgery resident calls you right now asking, look, should we take him to the OR tonight, or does he just need radiation?
You've already started dexamethasone, the standard first step.
Right, dexamethasone, good start.
But the clock's ticking. We need to make the call. How do we even start unpacking this?
Yeah, it's definitely a high-pressure moment. So first things first, let's get a handle on the landscape here. Spinal mets, unfortunately, they're common, really common in advanced cancer.
We're talking maybe 10% of all cancer patients might develop symptomatic spine mets. And if they already have known metastatic disease, that number jumps way up.
Oh.
And these tumors in the spine, they can cause, terrible pain, serious neurologic problems, loss of function, even paralysis. So knowing the usual suspects, the primary tumors that tend to go to the spine, that's kind of your first step in anticipating this.
Right. So the big players that often metastasize to the spine. Prostate cancer is a big one. Often those blastic lesions, right?
Yep, dense blastic lesions.
Then breast cancer, which can be lytic, blastic, kind of mixed.
Can be either.
Lung cancer, definitely, especially small cell lung cancer.
Critical one to flag.
Kidney cancer, those tend to be myelolytic, right, and really vascular.
Very vascular, very lytic, yeah. Thyroid cancer too. And then the blood cancers, lymphoma, and multiple myeloma.
Yeah, and you mentioned flagging small cell lymphoma, myeloma. Why specifically those?
Because those three small cell lung, lymphoma, and multiple myeloma are generally considered chemosensitive or radiosensitive.
Okay.
And that sensitivity is really important when they cause MESCC, that malignant epidural cord compression, because it might mean that upfront systemic therapy is a really good option, maybe even the preferred first step for some of those patients.
Ah, interesting. So it opens up another treatment path initially.
Exactly.
Yeah.
It's a key distinction to make based on the histology. Now, our patient, his MRI, showed a lytic lesion at T8.
Right, lytic.
So just to quickly clarify what that means for bone integrity. Lytic lesions, think of them as bone destroying. They literally eat away at the bone.
Like termites, you said.
Yeah, kind of like termites in wood. It creates weak spots, really compromises the bone strength, and massively increases the risk of fracture and, crucially, instability.
Okay, and blastic.
Blastic lesions are the opposite. They stimulate new bone formation. So on imaging, the bone looks denser, more sclerotic.
So strong.
Well, not necessarily better bone, but structurally they tend to be more stable because they're adding material rather than removing it. They can still cause pain, still cause compression, but less inherent risk of the bone just collapsing.
Got it. So phylitic versus blastic is a huge factor for stability.
Absolutely vital. And that leads us right into the next big step, assessment.
Okay, so assessment. Where do we start? Once we know what kind of lesion it is, we need to figure out the damage risk.
Precisely. Before we jump to any treatment plan for this guy or any patient like him, we have to answer two fundamental questions. They're totally intertwined.
Okay, what are they?
First, is his spine stable? Is it at risk of just collapsing under normal load? And second, what's the exact degree of his spinal cord compression? How bad is it, and how urgent?
Stability and compression grade. Got it.
Those two questions form the bedrock for everything else we decide.
And how do we start answering those? Often the patient's story gives us clues, right? The pain.
Bingo. The pain description is often our first major clue. We need to differentiate between two main types here: oncologic pain and mechanical pain.
Okay, oncologic pain. That's just the tumor itself causing pain.
Pretty much. It's typically constant gnawing, doesn't really change much whether you're sitting, standing, lying down. It's the tumor growing in the bone, stretching the lining, maybe hitting nerves nearby, often described as dull, aching, just always there.
Okay. And mechanical pain.
But mechanical pain is different, and it's a huge red flag.
Red flag. Okay. Why?
Because this pain gets worse, often much worse with activity. Standing, walking, any kind of movement or weight bearing. And critically, it gets significantly better when the patient lies down.
Like our patient, mid-back pain, worse standing, better lying down.
Exactly. That's the classic story for mechanical pain. And it strongly suggests that the spine's structural integrity is compromised. It's unstable.
The rickety chair analogy.
Perfect analogy. It hurts when you put weight on it because it's structurally unsound. That pain pattern screams potential instability.
So if we hear mechanical pain, what's the next step? How do we quantify that risk?
And that's where our validated tool comes in, the Spinal Instability Neoplastic Score, SIS.
Yes,
SINS.
it's a CNS score. Okay.
It's designed to help us systematically assess and quantify that risk of the spine collapsing. It takes the guesswork out of it, standardizes the assessment. Think of it like a structural engineer looking at a building after an earthquake.
Okay, yeah.
They don't just look at one crack, right? They assess the foundation, the beams, the materials, everything to judge the overall risk.
Right.
SINS does that for the spine using 6 specific factors.
6 factors. Okay, let's break this down. What's the first one?
First is location. Where in the spine is the lesion? Because the spine isn't uniformly stable.
Right. Some parts are more flexible, some more rigid.
Exactly. And the junctional regions where rigid meets flexible are inherently less stable. So the cervicothoracic junction, like C7 to T2, or the thoracolumbar junction, T11 to L1, those get 3 points because they're high-risk zones.
Okay. And our patient is T8?
Right. T8 falls in the semi-rigid thoracic spine, T3 to T10. That only gets 1 point. Less inherently unstable than a junctional zone.
Got it. Factor 2.
Factor 2 is pain. We just talked about this. If it's that mechanical pain, worse with load, better with rest, that's a big indicator of instability. 3 points.
And if it's just oncologic pain?
0 points.
Yeah.
Still needs treatment, but doesn't signal instability in the same way. Our patient has mechanical pain, so that's 3 points for him.
Okay. 1 plus 3. Factor 3.
Third is bony lesion type. Lytic lesions, the bone-destroying ones, they get 2 points because they directly weaken the structure.
Elastic.
Blastic lesions get 0 points. They're generally more stable. Our patient has a ligolytic lesion, so add 2 points.
Okay. 1 plus 3 plus 2. That's 6 so far. Factor 4.
Radiographic spinal alignment. This is looking for actual slippage. Is there any subluxation or translation, meaning one vertebra has shifted out of line with the next?
Like a building floor shifting sideways.
Exactly. If you see that, it's critical instability. 4 points right away. If alignment is normal, 0 points. Let's assume our patient's alignment is okay for now, so 0.
6 points still. Factor 5.
Vertebral body collapse. How much has the vertebral body itself compressed? If it's lost more than 50% of its original height, that's a major structural failure. 3 points.
The beam is buckling.
Pretty much, yeah.
What?
Let's assume our patient has significant collapse, consistent with his severe picture. So add 3 points.
6 plus 3 is 9. Last factor, number 6.
Number 6 is posterolateral element involvement. This means tumor involving the back parts of the vertebra, the pedicles, lamina, facets. These are crucial for stability.
The tripod analogy. Body and the 2 back legs.
Right. If there's bilateral involvement back there, meaning both sides are affected, it really destabilizes that posterior column. That gets 3 points. Let's assume our patient has this too.
Okay, so add another 3. 9 plus 3 is 12.
12 points total for our patient,
Yeah.
assuming those worst-case findings.
Right. And you mentioned a mnemonic for these 6 factors.
Yeah, to keep them straight. LPBRVP.
LPBRVP. Okay. Location, pain type, bony lesion type, radiographic alignment, vertebral body collapse, and posterolateral element involvement.
Got it. Keep that handy. It's super useful.
Okay, so our patient score is 12. What does 12 mean clinically?
Right. Interpreting the score is key.
Yeah.
0 to 6. Generally considered stable. Radiation alone might be okay.
Okay.
13 to 18. Definitely unstable. Needs urgent surgery, no question.
And 7, 12. That's where our patient falls.
That's the potentially unstable or indeterminate stability zone, the gray zone.
So, maybe surgery?
Not maybe. Here's the critical rule, the one you absolutely need to remember. Any patient with a CNS score of 7 or greater warrants an urgent surgical consultation.
7 or more, call surgery. Period.
Period. His score of 12 makes that call absolutely mandatory and urgent. You don't watch and wait with a score of 12. It's screaming, get the surgeons involved, NW.
Okay, crystal clear. SINS score is vital for the stability question. What about the other critical question, the degree of cord compression?
Right. For that, we use the Bilsky scale. It's based on the axial MRI images, the cross-sections. It gives us a standardized way to grade how badly the epidural space and spinal cord are being squished.
Bilsky scale. Okay, walk us through the grades.
Sure. It starts simple, grade 0. Just bone disease, no tumor pushing to the epidural space at all.
Okay.
Grade 1, there is epidural impingement, but no actual cord compression yet.
Impingement but no compression. Subtypes.
Yep, 3 subtypes for grade 1. 1A, tumor touches the dura, but doesn't deform the ventricle sac, that fluid space. 1B, it does deform the ventricle sac, pushes it in a bit, but still doesn't touch the cord itself. 1C, now it's actually touching the cord, abutting it. Oh, and this is key. You can still see CSF all the way around the cord. The cord isn't actually being squeezed yet.
Okay, so 1C is touching but not squeezing. CSF is still visible circumferentially.
Exactly. Then you get to grade 2. Now you have definite spinal cord compression. The cord is being squeezed, but you can still see some CSF around it. It's compressed, but not totally choked off.
So some buffer space.
Right. And finally, the most severe grade 3. This is spinal cord compression where there's no visible CSF around the cord. It's completely encased, circumferentially compressed by the tumor.
Like a vice grip.
Exactly. That's what our patient's MRI showed, Bilsky grade 3.
Okay. And this grading, Bilsky, it has big treatment implications, right? Especially for SBRT.
Huge implications. SBRT, stereotactic body radiation therapy, uses very high, very focused doses. The spinal cord is extremely sensitive to radiation. So, for safety reasons, we generally limit SBRT to Bilsky grade 1C or less.
Only up to cord abutment, but no actual compression.
Right. Once you get to grade 2 or 3, where the cord is actually being compressed, the risk of causing radiation myelopathy, serious, potentially permanent cord damage with those high SBRT doses, becomes, frankly, unacceptable for most patients.
So grades 2 and 3 usually mean?
Usually means surgery needs serious consideration first. Surgery can rapidly decompress the cord, create that buffer space back, and make subsequent radiation much safer.
Got it. So this all loops back to the neurosurgeon's question for our patient.
Exactly. The patient has MESCC, malignant epidural spinal cord compression, Bilsky grade 3, progressive deficits, SINS score of 12. Operate or radiate.
It feels like we're leaning heavily towards operate.
We are. And thankfully, we don't have to just lean on our assessment tools. We have high-level evidence to guide this specific decision.
Okay, let's hear it.
This brings us to the Patchell trial. Absolutely landmark study, published in The Lancet, 2005.
Patchell. Okay, what was the core question?
The question was direct. For patients with MESCC from solid tumors, is upfront surgical decompression plus radiation better than just radiation alone? Head-to-head comparison.
The definitive showdown.
Pretty much. And it really changed practice. Confirmed the vital role of surgery for the right patients.
So how is it set up?
Okay, they enrolled 101 patients. All had a single spot of MESCC from a solid tumor.
Inclusion criteria.
Key ones were: they couldn't have been paraplegic for more than 48 hours, so some function remaining, or only recently lost. And they needed an expected survival of more than 3 months, so they'd potentially see the benefit.
Makes sense.
They were randomized. One group got direct surgery, decompression, and stabilization, followed by standard radiation, 30 gray in 10 fractions.
Okay. Surgery then RT?
The other group got just the radiation,
Yeah.
30 gray in 10 fractions alone.
And it's worth noting, most of the surgeries were anterior approaches, getting right at the vertebral body where the compression often originates.
Got it. And the results?
Overwhelmingly favored surgery. Let's talk ambulation. The ability to walk. That's huge for patients.
Absolutely.
In the surgery arm, 84% of patients were able to walk after treatment. 84%.
Wow.
Compared to
57% in the radiation therapy alone arm.
84 versus 57. That is a massive difference.
Huge. Almost 30% more patients walking, being independent, just by adding surgery up front. It's a profound functional benefit.
What about patients who couldn't walk at the start, like our guy?
Even more striking there. If they couldn't walk initially, 62% in the surgery group regained the ability to walk.
62% regain walking, and with radiation alone.
Only 19%.
Wow, 19 versus 62, that really highlights the power of decompression.
Absolutely. And how long did they stay walking? The median duration of ambulation was 122 days with surgery
Okay, about 4 months.
versus only 13 days with radiation alone.
13 days, that's barely 2 weeks, compared to 4 months.
It's an enormous difference in sustained functional independence. And there was even a small survival benefit. Median overall survival was 4.2 months with surgery versus 3.3 months with radiation alone. Modest, but statistically significant, and kind of reinforces the overall benefit.
So Patchell's conclusion was pretty clear then.
Unequivocal. Surgery followed by postoperative radiation became the standard of care for MESCC in appropriate patients. It changed guidelines worldwide.
But like any big trial, there were critiques, right? Nuances.
Oh, absolutely. And it's important to know them. For instance, that 3.3-month survival in the radiation alone arm, that was actually pretty poor, maybe even worse than some older studies suggested it should be, raises questions about that control arm.
Anything else?
Well, probably about a third of the patients in the radiation alone group likely had unstable spines by today's CNS criteria.
And radiation doesn't fix instability.
Exactly. So maybe it wasn't a fair fight for radiation in those patients.
Yeah.
Also, the definition of walking was pretty minimal, just taking 4 steps. Doesn't necessarily mean truly functional walking.
Okay.
And as we mentioned, most surgeries were anterior approaches. Very effective, but not always feasible or the only way to do it.
Right, so these points don't erase the trial's impact, but give context.
Precisely. Helps us apply it smartly. Now, what about those chemosensitive tumors we mentioned earlier? Lymphoma, myeloma, small cell. Patchell focused on solid tumors.
Yeah, is the approach different for them?
It can be. For those histologies, upfront systemic therapy chemo, targeted agents with really close neurologic follow-up might be a reasonable first step.
Because they might shrink quickly with drugs.
Exactly. Sometimes the systemic therapy works so well and so fast that it effectively decompresses the cord without needing surgery right away. But it requires careful selection and very vigilant monitoring. If things don't improve quickly or worsen, then surgery or radiation is back on the table immediately.
Makes sense. Okay, so Patchell gives us the gold standard for surgical candidates. What about patients who aren't surgical candidates? Maybe they're too frail, too much other disease.
Great question. For them, conventional radiation therapy is our main tool for palliation, local control, trying to preserve function. And we have good data guiding our choices there too.
Okay, like what?
The SCORE-2 trial from 2016. It looked at MESCC patients and randomized them to 2 common palliative regimens. 20 gray in 5 fractions versus 30 gray in 10 fractions.
Shorter versus longer course? What did they find?
They found both worked really well for pain, like 87 to 90% response. And importantly, the ambulation rates were very similar between the 2 arms.
So the shorter course wasn't worse?
Nope. 20 gray in 5 was non-inferior to 30 gray in 10, which is great for patients, right? Fewer trips, faster treatment, same benefit. It really solidified 20 and 5 as a standard palliative option.
Okay, 20 and 5 is a solid choice. What about even shorter courses?
Good question. That leads to the SCORE-AD trial from 2019. This one compared a single 8 gray fraction against that 20 gray in 5 regimen for MESCC.
1 shot versus 5. How did that pan out?
Well, the 8-week ambulation rates were pretty close. 69% for the single fraction, 73% for the 5 fractions.
Sounds similar.
It was similar. Technically, the single 8 gray fraction just missed meeting the preset statistical goal for non-inferiority at that specific 8-week mark. It was a statistical nuance.
But clinically?
Clinically, it was non-inferior at earlier time points and later time points. So the takeaway is that a single 8 gray fraction is still a very reasonable option, especially for patients with a really poor prognosis where getting treatment done quickly is paramount.
Okay. So for non-surgical MESCC, 20 gray and 5 is a standard effective choice. 8 gray and 1 is reasonable too, especially for poor prognosis patients.
You got it. And just hammering the safety point home again, SBRT is generally off the table for Bilsky 2 or 3 compression. Sticking to conventional doses like these is safer for the cord in those situations.
Got it. Safety first.
Yeah.
Now, what about newer things? Any exciting advances changing how we approach spine meds?
Yes. One really exciting area is prophylactic radiation. treating high-risk asymptomatic lesions before they cause problems.
Proactive instead of reactive.
Exactly. Trying to prevent those really bad skeletal-related events, SRES, like fractures or cord compression, from ever happening.
SRES. Okay. Is there evidence for this?
There is. The Gillespie study, a phase 2 randomized trial, published just last year, 2023. Really important work.
Gillespie study. What did they do?
They identified patients with asymptomatic bone mets considered high risk, things like bulky disease, lesions in critical spots like the hip or shoulder, or relevant to us today, lesions in those junctional spine areas, especially with posterior element involvement.
The spots we know are prone to trouble.
Precisely. The weakest links. They randomized these patients to either get prophylactic radiation to that high-risk spot or just standard observation.
And the results?
Pretty stunning, actually. Prophylactic radiation dropped the rate of SRES at 1 year from 29% in the observation group down to just 2%.
29% down to TWO%.
Yeah, a massive reduction in fractures, cord compressions, the need for urgent surgery or radiation later on. Just huge.
That is truly remarkable, preventing almost all those events.
It is. And get this. They also saw an improvement in median overall survival, 1.7 years in the radiation group versus 1.1 years in the observation group.
Wow, so preventing those bone events actually helped people live longer, too.
It seems so. It highlights how devastating these SRES can be and the massive benefit of preventing them proactively. It's really shifting the paradigm.
Okay, that's definitely something to keep an eye on. Now, let's bring all this fantastic knowledge back to our patient, synthesize everything for that neurosurgeon's call.
Right. Time to put it all together.
So recap. 65-year-old man, prostate cancer, acute progressive leg weakness, new urinary retention, mid-back pain, worse standing, better lying down mechanical pain.
Sure.
MRI shows iledylic T8 lesion. We calculated his SINS score at 12, potentially unstable, definitely needs surgical consult.
Check. SINS 7 triggers the consult.
And his Bilsky grade is 3 circumferential cord compression, no CSF visible.
Check. Severe compression.
So the neurosurgery resident asks one last time, or tonight, or just radiation?
Okay. The answer needs to be confident and clear based on everything we've just discussed.
My answer would be, given his acute progressive neurologic deficits, the leg weakness, the retention, and that Bilsky grade 3 circumferential compression, this is a clear, urgent indication for surgical decompression and stabilization now, tonight.
Absolutely. And you back that up with the level 1 evidence from Patchell, right?
Exactly, cite Patchell. Surgery plus radiation gives significantly better odds of walking 84 versus 57% and keeps patients walking much longer, 122 versus 13 days, compared to radiation alone in this exact situation.
Radiation alone just can't fix the mechanical problem here.
And his SINS score of 12 also screams instability, which radiation also can't fix. It further mandates surgery.
So all the pieces, the acute neurology, the Bilsky grade, the SINS score, the Patchell data, they all point in the same direction.
Unequivocally towards urgent surgery. We'd tell the resident, yes, take him to the OR tonight. Then we'd plan for post-operative radiation once he recovers, usually in a week or two, to help with local control.
Perfect. It's a great example of how integrating all these assessment tools and evidence leads directly to the best clinical decision. Makes the complex seem logical.
All right, fantastic discussion. Let's crystallize some of the key takeaways with our clinical pearls.
Love the pearls. Let's do it.
As you start, pearl number 1.
Pearl 1. The SINS score is your go-to for spinal stability. Remember the magic number. 7 or greater means potential instability and requires an urgent surgical consult. Don't sit on it.
Pearl 2. The Bilsky scale grades your epidural compression from 0, bone only, up to 3. Circumferential compression, no CSF. And remember, SBRT safety generally means limiting it to grade 1C or less. Higher grades need caution, likely surgery first.
Pearl 3. Know the Patchell trial. It's foundational. It established surgery plus postoperative radiation as the standard of care for MESCC from solid tumors, dramatically improving ambulation, 84 versus 57%.
Pearl 4. For patients who can't have surgery for MESCC, 20 gray and 5 fractions, thanks to score 2, is a great palliative radiation option, and even 8 gray and 1 fraction from SCORAD is reasonable for those with very poor prognosis. Tailor it.
And Pearl 5. Think proactively. Prophylactic radiation to high-risk asymptomatic lesions like junctional spine with posterior involvement drastically cuts down skeletal-related events from 29% to 2%, the Gillespie study. Huge potential impact.
Excellent pearls. Ready for a quick board blitz? Test ourselves?
Absolutely. Ready when you are. Fire away.
Question 1. A 70-year-old man, metastatic prostate cancer, has severe thoracic back pain. It's worse when he stands or walks, much better lying down. No neurodeficits currently. What's the pain type and what's the critical next step? A. Oncologic pain. Start steroids and radiation. B. Mechanical pain. Evaluate spine for instability with CNS score. C. Radicular pain. Get a nerve block. D. Visceral pain. Get an abdominal CT scan.
Okay, the pain description, worse with load. Relieved by rest, that is textbook mechanical pain. So the answer is B, mechanical pain signals potential instability, so the critical next step is a SINS score assessment, and based on that, probably a surgical consult even without neurodeficits yet.
Yeah.
Classic board vignette.
Perfect. Question 2. You calculate a SINS score for a patient. Lytic T11 metastasis. The total score is 14. What does this score mean? A. Spine is stable. Radiation alone is fine. B. Indeterminate stability. Surgical consult is optional. C. Spine is unstable. Requires urgent surgical consultation. D. Score isn't valid for the thoracic spine.
All right, SINS score interpretation. 13 to 18 means unequivocally unstable. So a score of 14 indicates an unstable spine. The answer is C. He needs an urgent surgical consult for stabilization. It's not optional. It's mandatory to prevent neurologic decline.
Got it. Unstable. Urgent consult.
Question 3. According to the Patchell trial, what's the primary benefit of adding surgery to radiation for MESCCA, lower rate of radiation myelopathy? B. Higher likelihood of maintaining or regaining walking ability. C. Shorter overall treatment time. D. Better local tumor control at 1 year. The key word is primary benefit shown in Patchell. While other things might be true, the standout practice-changing finding was the dramatic improvement in ambulation. So the answer is B. That 84% versus 57% walking rate was the core message driving the change in standard of care. Functional outcome was king.
Excellent. Nailed the blitz.
Huh?
So we've covered a ton on stability and compression management, but medicine is never static, right? There are always ongoing debates, controversies.
For sure, and it's good to be aware of them. We touched on the Patchell critiques, the potentially weak RT arm survival, the instability confounder, the minimal definition of walking, the focus on anterior surgery. These are important points for critical appraisal, not to dismiss the trial, but to apply its findings wisely. Understand the context.
Right. And on the flip side, the advances are really exciting. That prophylactic radiation from Gillespie, that feels like a real game changer.
It really does. Shifting from reaction to prevention for SRES could have such a massive impact on quality of life, independence, maybe even survival, as the study suggested. Figuring out exactly who benefits most and how to best integrate that will be key moving forward.
And looking ahead, there are other complexities too, aren't there? Like balancing Patchell's surgical recommendation with really effective systemic therapies now available for some cancers.
Exactly. If a new targeted agent can shrink a tumor and decompress the cord rapidly, when do you try that first versus going straight to surgery? That requires really tight multidisciplinary coordination.
And the tough ethical calls too. The patient who fits Patchell criteria perfectly for surgery, but is just too frail or comorbid for a major operation.
Yeah. How do you best honor their goals of care in that situation? Those are the challenging discussions we have in tumor boards all the time. No easy answers sometimes.
And that constant evolution, those nuanced discussions, especially around advanced techniques, that actually tees up our next session perfectly.
It does indeed.
We hope you'll join us next time for Spine Mets Part 2, an SBRT technique and re-irradiation workshop. We'll really dive deep into modern spine SBRT patient selection, target delineation, those crucial spinal cord constraints, and tackling the challenge of re-irradiation.
This is going to be a good one.
Yeah.
Really practical stuff for modern radiotherapy.
So wrapping up today's discussion on spinal metastases management.
We really covered the essentials, differentiating oncologic from that critical red flag mechanical pain.
Rigorously assessing stability with this SINS score, knowing when to make that urgent surgical call.
Precisely defining the Bilsky scale for compression. Understanding the safety limits for SBRT.
Dissecting the pivotal Patchell trial, knowing why surgery plus radiation is standard of care for MESCC to maximize walking.
Reviewing those conventional RT options like 20-5 or 8-1 for non-surgical patients, and touching on the exciting potential of prophylactic RT to prevent SRES.
You can get show notes and complete practice oral boards over at radoncsmartlearn.com. That's RADONC smartlearn.com.
And make sure you subscribe to the Radonc Smart Review so you don't miss our next session on Spine SBRT.
Thanks so much for tuning in.
Thanks, everyone.